So this afternoon, you have to pair with your classmate to see the patient, and most of the patient go to our Toina clinic. They are looking for some muscular pain. So today the lesson is concept to introduce some muscle skeletal assessment, the normal or abnormal posture, and then we will have a practice on upper body assessment because it is quite important because most of the patients they are looking for some neck and shoulder. So before after we do the consultation, okay, we need to do some assessment for them. Okay, so mostly on neck and shoulder, and then we can have a diagnosis, and then we can have a treatment. So the third part, upper body assessment, that's quite important for everyone. So this morning I will make sure everyone have practiced good enough on the upper body assessment, so that you can find it's quite easy on your clinic. And on your clinic, usually we have about 1 hour for Toina patient, okay, for return patient, okay. So because I'm not worried about the initial consultation of the Toina session, because every initial patient they have 1.5 hours, so usually you have enough time to do consultation and then treatment. So the thing is the return patient, you only have 1 hour, okay? So usually, as I said before, usually you spend 10 to 15 minutes for the consultation and about 10 minutes for me because you have to report to me, all right? Okay, sometimes you have to wait because we have many students to report to me. And then after that, when you come back to the consultation room, you might only left 30 minutes. So usually we'll spend about 20 minutes for the treatment. Okay, don't do too much time, otherwise you don't have enough time, okay, to finish the treatment. Because usually we are quite fully booked in the Toina clinic, so we need to make sure all the room you should finish on time. Okay, let's say if the patient the time slot is 1 p.m. to 2 p.m., so we need to finish by 2 p.m. Okay, and then we can tidy up the room and reset the room and leave the room for the next patients. Okay, otherwise they all delay. Okay, so about 20 minutes for the treatment. So you will have a very good treatment plan about how to do the treatment. So usually when you report to me, so you need to let me know probably you will spend how much time on which part of the human body. Okay, let's say you will start with maybe 5 minutes rolling, or maybe some of the shoulder channel, and maybe 5 to 10 minutes on the neck shoulder, on some arching point or some shoulder point. You need to tell me your treatment plan, right? The time of the treatment plan. Okay, because time management is also very important when you go to the clinic. Okay, you can't waste your time in the clinic. Okay, otherwise you can't see many patients. Okay? And then after the treatment, you also have to write down, type in your medical records. Well, you need to finish on the same day the medical record. Okay? Yeah. And you have to finish on the campus as well. Okay, so the time is quite tight. Okay, right. So first we will have some introduction to the muscular skeletal assessment and the posture and gait assessment. Okay, and then the most important part is the upper body assessment, because you use for the clinic this afternoon. Right. So why is the posture assessment is quite important? Anyone can tell me?
Identify what CD channels are associated with whatever's going on.
Yes, because this is also one of the diagnoses where people is walking into your consultation room. Okay, you can feel their posture. Okay, to have initial maybe diagnosis to see what's going on. Okay, because some people, because if their leg is not balanced, also okay, so you can find something, or their the left and right shoulder they are not balanced. Okay, so you can see what's going on. So the posture assessment is quite important in Toina, okay, as well as the TCM diagnosis as well. You can't only do maybe consultation, pulse or time without any posture assessment, because it's also very important. Because including Western diagnosis of neck shoulder pain, and also sometimes it's including our channel assessment as well. So the posture assessment is quite important. Right? Because the body needs alignment in how various parts, because they're related to each other, and also every channel they are related to other channels as well. And this is to see how balanced our body. Okay, if the patient, their general health is quite good, normally their posture is nearly balanced. Okay, no one have 100% balance, but nearly balanced is also tell you the patient in their general health is quite good or good enough. Okay, and okay, so there is quite many factors affect your posture, okay, or patient's posture. So the first one is structure, scoliosis, extra ribs, okay, and because you know every one or every nations they may have some different in their bone length, okay, and their age, okay, child, adult, or elderly, they all are different, have different posture. And physiological, okay, they have pain, discomfort, or pregnancy, female pregnancy, okay, and they have illness or pain and fractures of the bone, okay, and the different job, okay, so your job on the desk or your job as a worker, they may all have different factors affect their normal posture. Or recreation, reduced sport, okay, or temperature will also affect the change of posture as well. Okay? And also quite important in TCM diagnosis, so emotional is also quite important. Okay? Because emotional usually will make some called stagnation or blockage on our certain channels, so mostly maybe liver channel or spleen channel or heart channel. Okay, they will also affect the tightness of your muscle or your certain channel or the muscle across the channel. So it will also affect your posture. So on the other hand, if the people have abnormal posture, okay, that means the certain channel might have stagnation. So at that time, you have to palpate the channel to see which channel or which certain channels or active points have some stagnation or some blockage as well. Okay, as well as the qi and blood stagnation or deficiency. Okay, so sometimes stagnation and deficiency may be different. So on last lesson we have said if people have stagnation on qi or blood, usually their muscle is a bit tight. Okay, and if their muscle is quite soft and weak, usually it's the deficiency. So tightness and the deficiency and the weakness of the muscle, they will also affect or create different posture of the patient. So the posture is quite important because it helps us to do some diagnosis. Okay, so usually we divide human body into three different planes. Okay, we call sagittal, frontal, or transverse. Okay, so I have a picture for you. Okay, so it is the first one sagittal. So which divide human body on the left and right side. Okay. And horizontal is on the upper and the lower. Okay, divide between the human body, the upper and lower, and the frontal is divided people on the front and back. Okay. This is a concept. Okay. This is not too important in TCM, but this plans of movement is quite important in physio and chiropractic. Okay. Because they need to use their hand to adjust your joint or adjust your bone for chiropractic, so that is quite important. They call 3D plans, something like that. Okay, and sagittal visualization is just let you know. Okay, so all the movement, okay, of the when you turn to the front or turn to the back, it's all about the sagittal plan. Okay? It's just like a concept. And the lateral is the horizontal. Okay? And then transverse is the frontal plan. Okay? This is just the concept. And the most important is what you think is normal posture, because you know nobody is perfect, not everyone is perfect. We can't see 100% perfect body in nowadays. So what is the normal posture you think? Are all of you in normal posture or no? No, yeah, definitely not.
Not with the chair.
Okay. Yeah,
No,
definitely
not.
definitely not one in a very normal posture. Okay. So most people, their normal posture is quite poor. Okay. So in nowadays we are not talking about the normal posture. We are talking about the ideal posture. Okay. They are nearly normal, but it's not 100% normal. Okay. It's ideal posture. Okay. So yep, I will show you what is the ideal posture. Okay, and this is the standard postural alignment. Okay, this is more for your lower body. Okay, it's just let you know the level and the rotation of this bone called ESIS. So this one. Then normally when you touch yourself, it's on the same level. Okay. So if these two that is on different level, so maybe like this one. Okay. So normally the posture is quite good. Okay. So if the body is more tend to the right side like this one, so you can only feel one side. Okay, alright. And if the posture is mostly like this, on the left side, you can only feel the left side. If you can feel nearly both sides, okay, on one plane. Okay, so normally the posture is ideal. Okay, we not call the normal ideal posture. Okay, so we can check of this. Okay, right. Yeah.
And you would obviously assess that when
That
they're
one's
standing.
dimple, right?
Yeah, when they standing, no, yeah,
Lying
not
down.
sitting.
Yeah.
When standing, so we can check this one, and normally we can check maybe one side is more than other side. Okay, okay, we can feel both sides, but usually one side is more than another side. So if we can check maybe right side is more, that means the posture of the body is normally turned to the right side. Okay, so if the body is turned to the right side, okay, normally the muscle on left side might be quite tight. Okay, because it's extend the left side of the muscle. Okay, because the people turn to the right side, so all of the left side of the muscle is quite extended. Okay, so they may feel tightness on the left side. Mostly it's on left side. Okay, so the patient can feel on the both side, but mostly on the left side. So at this moment, the issue is mostly may show on the left side. Okay, this is a simple diagnosis of this one. Okay, so if they turn to the left side, it's mostly the symptoms is on the right side. Okay, but it could also happen on the left side, but mostly it's on the right side because when you rotation to the left side, okay, your right right side of the muscle is extended. Okay, right. This one. And yeah, this one is more for the lower body. Okay. And then we have a situation like this. Okay. So if the patient, the lower back is like this one. Okay. So like this one. Maybe the left side is higher than the right side. So normally the leg length is imbalanced. So one side may be long and one side is maybe short. Okay, so we need to check as well. Okay, so this one is a very simple analysis to see which side is more tight than another side. And also maybe different angle of the knee that we can check as well. Because when you rotate to your right side, your knee's ankle will change as well. Okay, and your the angle of your knees and also your ankle will change as well. Okay, so this is very simple and just for the rotation of PSIS. Okay, this one. Okay, and the standard lateral alignment. Oh, okay. So that this one is quite common imbalance. Okay, so the upper cross and lower cross because our spine is usually balanced. Okay, they have a S sharp that is balanced. If there is not balance, usually we can see nowadays most of the people their posture. This is a normal posture. Okay, so but most people their posture is like this. So you can see their posture is like this. Okay, this is we call the upper cross and lower cross symptoms. It's usually the weakness of this part of the muscle. Okay,
On the front.
on the front.
Really?
Okay, yeah. So they mostly their body posture will put on the front side. Okay, and then also the ASIS will usually we're getting low. The PSIS will getting high and ASIS will getting low. So that is like this. Okay. So if the muscle on the upper body is getting weakness, so usually the upper body will put on the front, and the lower body, okay, the lower body will like this. This on the front, so the lower body will like this. They're getting up, okay. So the joint, the lower back, they will not balance, and it will also affect our hamstring. So the hamstring, the tension is usually very high. Okay. For this symptom, we can quite easy to firstly to check the hamstring tension. So if the hamstring tension is very tight, okay, so usually the upper cross and lower cross were very weak. Okay, so most of people have these symptoms. So on this symptom, so which muscle you think is the most affected muscle?
What did you say?
Which muscle you feel we should train?
The tightness on the chest and the tightness on the hamstring
So it's
and the hip flexors because of the anterior tilt, I think,
I'd go hip flexors.
and then encourage them to train the pectoralis muscles.
Usually, we should train lower back first.
Lower back.
Usually, we should train lower back first because why? Because the lower back part, okay, they are connect our upper body and the lower part. So usually, they have most of the tension is on this area. So we should train the lower back first. Okay, we should train the lower back first, and we should train the hamstring. Okay, and the above and the lower back first. Okay, to let the muscle be more softer, and then we train the upper body.
And in a TCM point of view, are we going to disperse
Yeah, we
down
need to.
because it's the bladder and
Usually it's
gallbladder,
gallbladder and bladder channel.
bring
Yes.
it down.
Yes, usually it's bring that. Yeah, usually they relate to bladder or in gallbladder channel.
Yeah.
Okay. Alright. And after we try this, and then we can try the upper body, but we use different technique to try the upper body. Okay, because you can see these two muscles is become more tightness. Okay, so we need to relieve. Okay, these two muscle, and then this two muscle is usually is very weak. Okay, so we need to use some pointer technique or other technique to nourish this muscle. Okay, so usually if we learn cupping at week 7, usually we can do pointer and then we can do cupping on this muscle. But we can't do cupping here, alright? Because usually we can't do cupping on the front side. So we do pointer and cupping, okay? On that you will lift the muscle, and then we might can do some slightly gua sha on here to nourish the muscle. Okay? And gua sha is not relief technique only. We can also use gua sha to nourish. Okay? Because the most soften you do on the gua sha is a nourish technique. Okay? More strong is a relief. So we can do gua sha. Okay? You may find gua sha is quite helpful in pointer technique. And cupping as well. Okay? And the muscle vision is usually is a nourish technique. It's the raising and nourish technique. Okay? In TCM technique. Okay. So on week 7 we can use different method like muscle vision, cupping and gua sha. So I would like all of you on each session for patient not only use the toner technique, okay? You can use at least one of the muscle, cupping or gua sha. Okay?
Is that from the week 7 or from now?
From the week 7,
Oh, not from now.
not from now. Okay?
From now to week 7, we only tweener.
Yes,
Okay.
because we haven't learned this technique yet.
Okay.
Okay, but
Okay.
on week 7, we should start use other technique,
Okay.
other than only do the toner for the.
All right.
So and then we talk about the baseline analysis, functional walking. You can through the walking of the patient. Okay, they walking through the waiting room, and you can have the very initial access for the posture and see how they are walking. Like the head orientation on the level of the shoulder. It's very easy to check what's wrong with the patient. Okay, so normally the level of the shoulder is not balanced. Maybe one is lower and one is higher than the other side. Yes, we can have a video to see.
Sorry, Stephen,
Yep.
just with the, if one side's slouchy, are we saying that it's the left side slouchy, the right side is what's tight?
Yes,
Or
if one side is lower than the other side,
it's the higher side that's tight? or
higher side
needs
is tight.
attention?
Yep. The
Needs
lower
attention.
side is weak,
Oh, that's
and the higher side is more
because
tight.
the slouchy is holding all the weight.
Mm.
But so you need to treat the right side more?
More on relief, and the left side is more on nourish side.
No, okay.
Yeah. Okay, this is talking about the case analysis. We have some video to see first.
now going to demonstrate a couple of gaits. It would be a great shame for a patient to come to us with an abnormal gait and for us to send the patient for testing or consultation when the diagnosis might be fairly evident in the gait. The most common gait you'll see is the hemiplegic gait, and this is one that you see in hemiplegia where the arm is typically in this posture and the leg on the affected side is typically somewhat stiff, and they will then have a gait that looks something like this. And the characteristic of the gait is the circumduction of the foot. The fact that the foot is making a circle like that is what makes this gait so characteristic. If the condition is mild, the hand may not be flexed up like that, and the only manifestation might just be a little circumduction, and the hand may not be swinging normally the way the other hand swings. So that is called the hemiplegic gait. It's important to understand why they do what they do. When you cut the parietal tract on the left side, you have abnormalities of tone that manifest on the right side. So you develop flexion hypertonia in the upper limb and extensor hypertonia in the lower limb. And that accounts for the leg being like that and the hand being like this. In addition, they develop much more distal weakness than proximal weakness. Their shoulder is strong, the fingers are very weak. The thigh is strong, but the foot is weak, and so they have foot drop. And so the circumduction comes about because A, they have extensor hypertonia, so the leg is stiff. Otherwise, they could just step like this, they could go like this. And B, because they have foot drop, because they have weakness distally, they can't lift up the leg and step like that, so they wind up circumducting. So this is the most common gait we will see around here probably. It's called the hemiplegic gait. Another gait that we would commonly identify is the gait of Parkinson's disease. It's a posture that's characterized by universal flexion. Every joint is flexed, and the patient typically will take very small steps. This is called a festinating gait. The French call it the marche à petits pas, the walk of little steps. And there might also be an associated tremor with the gait. The patient may have a myriad other abnormalities related to the Parkinson's
Have you ever
that
seen
we're
a
not going to
Parkinson's
cover in
patient?
this session.
Yeah, they come in different ways.
Another gait that's very helpful to recognize, and it may be one that you're all familiar with from watching police videos and hopefully not from personal experience, is the cerebellar gait. The cerebellar gait is characterized by a broad stand and by a wide staggering quality to it. People will tend to fall towards the side of their illness, so if the illness is in the cerebellar hemisphere on the left, they might fall in that direction. When asked to stand still, their trunk may sway like this, and that is called titubation. And obviously they would have problems with all the other cerebellar tests. One caveat, many people think of the Romberg test as being a test of cerebellar disease. The Romberg test has nothing to do with the cerebellum. The cerebellar patient is already swaying, and it gets a lot worse when you have them close their eyes. But the Romberg test is really a test of proprioception. When you and I are standing like this with our eyes open, we are getting signals from our joints to tell us where we are in space. If, however, you have a problem with proprioception because of your peripheral nerves or posterior columns, then you're relying on your eyes to tell you where you are in space, and therefore, the moment you ask the patient to stand still and close their eyes, the patient begins to sway, and that is a positive Romberg test. It has very little to do with the cerebellum. Talking about proprioception leads me to the other gait related to proprioception. Once again, if you have trouble with your proprioception and cannot feel when your foot has arrived on the floor, you are relying on a lot of visual cues, and especially in the dark, you might develop what's called a stomping or stamping gait, where you tend to walk like this, needing to slam your foot down to get the vibration in your trunk to let you know that your foot has landed. So this gait may be much more prominent in the dark and not as evident in the daytime because they can see where they're going. A gait that we should mention in the context of the hemiplegic gait is the gait that's commonly seen in cerebral palsy. It's a diplegic gait, if you will, with hemiplegia on both sides. And it's a gait that I'm sure you've seen often in children and in adults affected by this from childhood. Typically, the patients have extensor spasm and almost seem to be walking on tiptoe. And although they have some circumduction, they have a lot of abductor spasm that keeps their feet close together. So they tend to be walking on tiptoe. The arm is flexed like this, and the adduction is a prominent feature. In fact, in some parts of the world where children do not get adductor releases, you might actually see a scissors gait, where the leg swings all the way over to the other side. And again, that is another manifestation of the diplegic gait. I want to talk about a gait that happens in people with myopathy. And this is a gait where the patient develops a wobble. And in order to understand this gait, you have to do a couple of things with me, if you don't mind. Put your hands on your hip, if you would. And appreciate that when you take a step forward, the hip on the side where you are stepping forward, that hip actually moves up. It moves up, and it's a function of having very strong pelvic girdle muscles that allow you to do that. If you have a myopathy, when you lift your leg up to take a step, because you can't hold your pelvis up and stabilize it, there's a tendency for the hip to fall on that side and for you to fall over. And to compensate for that, you lean your trunk this way. So you develop a waddling kind of gait, compensating for the fact that your pelvic muscles aren't strong. You get a waddling kind of gait, leaning away from the side where you have weakness. In a sense, it's a manifestation also of the Trendelenburg sign. The Trendelenburg sign says that when you lift the hip on the affected side, the pelvis sags down, and it's a suggestion that you have weakness in the pelvic stabilizing muscles. Another gait that we'll discuss is the neuropathic gait. If you have a peripheral neuropathy and you have foot drop, then typically you have to have a high stepping gait, otherwise you will trip on your foot and fall forward. So patients with neuropathy, especially if it's bilateral, will have a gait like this, which is nicely also called the equine gait, or the stepping or steppage gait. And the reason they do this is they can't step forward without tripping on their foot, because they can't really dorsiflex their foot because of weakness. The foot is weak, and so to overcome that weakness, they have to lift it up like so. The coliform gait does not, in my mind, strictly constitute a gait. These patients are already exhibiting writhing movements, involuntary movements when seated, and when they walk, they can have the most bizarre sorts of gaits. And I don't think it's fair to call it a gait, because really the involuntary movement is manifest in pretty much everything they do. I would offer as a caveat that all our hospitals have long corridors, great opportunities to watch patients walking towards you, away from you, and I encourage you to make a habit of studying gaits as people come and go, and realize what a miracle it is for people to have a normal gait, and how easily it is rendered abnormal by disease.
Oh, yes. And also one important thing is before you go to the consultation room, before you do consultation, you should wash your hands. Yeah, this is also a requirement for CMBA. Okay. Alright, that is all the abnormal things.
For anyone with dementia, do not drink warm water. Did you know that memory loss is not a condition of the mind? Most people don't.
Hip abductors and keep the pelvis level during unilateral stance phase. Notice that in the Trendelenburg gait, the hip is dropping to the unaffected side, while there is a slight lateral flexion of the trunk to the affected side. Hamstrings extend the hip and flex the knee, while the gluteus maximus acts as an accessory hip extensor. During walking, hamstrings prevent the trunk from bending forward following heel compensate for the paralysis of the vasty muscles, notice that the knee on the unaffected side is completely extended just before the heel strike. After the heel strike, the trunk is bent slightly forward to keep the center of gravity anterior to the knee. The iliopsoas and the adductors slow down the extension of the hip at the end of stance phase and initiate flexion of hip at the beginning of the swing phase. When the adductors are paralyzed, flexion of the hip on the affected side is accompanied by hip and thigh abduction. The triceps surae muscles flex the flexor foot and regulate the tendency of ankles to collapse in dorsiflexion. When these muscles are paralyzed and the foot can no longer be plantar flexed, the patient tends to walk with very short steps to keep weight back on the hip.
He's got flat foot.
Anterior tibial compartment muscles dorsiflex the foot and extend the toes. Paralysis of those muscles lead to foot drop. To compensate for this loss, the patient tends to walk with a high stepping gait to clear the ground. When the patient walks quickly, the foot on the affected side lands on the heel and the forefoot slaps on the ground. When the patient walks so slowly, he tends to land on the forefoot.
I think this is
Today, I'm going to discuss
abnormal kind of. Usually, it's very difficult to remember all the abnormal gaits. But when people come with the abnormal gaits, if you can't remember, actually it's very difficult to remember. I'm not asking you to all remember the abnormal gaits. Actually, it's very difficult. So no matter what the gaits or what the walking posture come to your consultation room, you can also do the assessment for the muscle. Very simple concept is to just check which part of the muscle is quite tight and you will lift the muscle, and which part of the muscle is weak to nourish. Okay, this is the TCM. This is the TCM treatment, because TCM is not have this too many different or difficult gaits or different posture. We only talk about qi and blood deficiency and stagnation. And all of these abnormal gaits is also sometimes, not all of them, is most of them is also affected by the brain as well and the nerve as well. So in acupuncture session, normally we may need to also put the needle on certain part of the head, okay, to improve the movement. But for turn-on session, firstly we need to train the muscle first. Okay, if you still have the time, you can train on the head as well, on certain maybe movement part or sport part of some certain area or some of the certain points on the head as well. It can also help. Okay, it's also help them to trade with this abnormal case. It can improve. At least it can improve. We can't trade. Okay, we can't help trade, but we can improve. Okay, that's it. Alright. Okay, and okay, this part is quite important. So it's the upper body scan. It's about the functional movement. What is the normal movement and normal movement of the cervical spine and the scapular girdle. Okay, so which is neck and shoulder. That's very important. Okay, so and you can quickly assess the area of dysfunction giving rise to what signal channel or pause may be affected. So the assessments including active movement. Active movement is the movement moved by the patient themselves, okay, to assess the range of movement. And the restrictive range of movement is where practitioner, that means you, apply some force to opposing the range of movement to assess the weakness or the strength or the function of the muscle. Okay, is the muscle is strong enough or it's quite weak, so it's assessed by us. Okay. So the goal of this assessment is to be complete in under 5 minutes. So usually spend maybe 5 to 10 minutes in total. It's very hard to only spend 5 minutes because some of the cases is quite complicated. Right. Okay. So the step in the scan is usually we check the cervical spine first and the scapular girdle. Okay. Right. And then I will tell you what is the normal range of movement of the neck. Okay. So firstly, the forward extension of our chin to the chest. Okay, the normal range of movement should be about 45 degrees to 50 degrees, so like this. Okay. Normally we can't use our chin to touch the chest. The range of movement should be around 45 degrees to 50 degrees. So if the patient they can't touch with the 45 degrees, so normally the muscle, okay, is this muscle problem. Okay, the problem is from the back. Okay, if they can't touch. Okay, if the fixation is not enough 45 degrees, the problem is from the back. Okay, and the extension. Okay, this one. So usually it's 85 degrees. And the anterior flexion to here to the shoulder. So like this. It's about 40 degrees. About 40 degrees. So this is also assessment to check which side is strong or which side. So let's say if on the right side they can touch maybe 40 degrees, and on the left side they may only can touch 20 degrees. So the problem is on the right side. Okay. If they turn on the left side, okay, the range of movement is not enough 40 degrees. So the problem is on the right side. Okay. This muscle is too tight. Okay, so we can't move more to 40 degrees.
What happens if you feel the pain on the side that you're going to?
When you do this
Yeah.
posture, okay. So the problem is maybe on your shoulder.
On the side that you're
Yeah.
tilting to?
Mm. And also the rotation, turn your head to your right and left, usually it's 90 degrees. Okay. When you do this, you make sure they are not turning their spine, but only turn their head. Okay. So like this, usually it's 90 degrees, usually. Okay. Alright, yeah, this is the normal, the active neck movement. That is movement by the patient themselves. Alright, so what is called restriction? So when we do the first movement, maybe let's say chin to chest when we bring down. Okay, so we have hand, we have a palm. Okay, right, like this. On the forehead to do a restriction to check the movement. Okay, if they can easily do the movement as well, that means the muscle, the strength is okay. So if when you put the palm, okay, on the forehead, and they can't do this posture or very difficult to do, that means their muscle is very weak. Okay. So as well as the extension as well. So if you put the hand on the head of the head and you can't do this, that means your muscle is very weak. Okay.
Restriction.
Get the restriction, and like this one as well. Okay, we put a hand on top of the head. Okay, to see the restriction, the muscle. Okay, to check the force of the muscle. And this one as well. And on the rotation, so normally we put the hand, okay, on both sides. Okay, to see
Yes.
the rotation.
And then the lateral flexion.
Check. Okay. Usually, each side will for about 3 seconds.
Okay.
and the shoulder, the range of movement of the shoulder. So normally the forward flexion of your shoulder is you can do 180 degree, and extension normally is 60 degree. Okay. If less than 60 degree, that means your shoulder okay or something wrong. Okay. Right. And the extension as well is 180 degree. And this one as well. Normally this one we can do 90 degree. The rotation
Media gitu ya. Stop sign.
and the horizontal extension we can have like this 30 to 45. Okay. When we raise up our arm, yeah, 30 to 45. Okay. This is the range of movement of the shoulder. Okay. So some people they may come from the frozen shoulder or the shoulder problem. Yes, so you can do the range of movement for the shoulder. This is the test. Okay, so I find a video in YouTube for this test, so you can see what's going on this chair. This test.
This video, deltoid.
Deltoids.
Which was anterior deltoid. Anterior deltoid. Posterior. Yes. Ini apa? EAS. BS.
ASIS, anterior, posterior.
Mana saya tak bisa sentuh.
Bisa apa tu?
Oke. Dikit lagi
Jam.
sampai.
Dikit.
Ini lebih jauh. Segini.
So maksudnya ini saja.
Kenapa?
In this one is the one that tight.
Masih dirilis.
Dirilis mana?
Ini
ini
ya
ya.
sama ini
Scapula.
sama anterior.
Subscapular.
Subscap sama
Best
anterior
and
juga.
worst dinner for your waistline. What's for dinner?
What about pasta?
One serving of
Hungry.
The back scratch test. The back scratch test assesses the general
goodness.
shoulder range of motion by measuring how close the hands can be brought together behind the back. The back scratch test is a measure of the senior fitness test protocol developed by Jones and Rickley, designed to test the functional fitness of seniors. Patient instructions. The subject stands and reaches one hand over the same shoulder with the palm down and with the fingers extended, and reaches as far down the back as able. The subject then places the other arm around the waist into the low back with the palms up, fingers extended, reaching up the middle of the back as far as possible.
Ada tes ini juga.
The subject tries to touch or overlap the middle fingers.
Ini untuk cek apa ya?
The subject reverses arms to test which position generates the best result. Once the best position is determined, the subject practices the test twice. The observers make sure the middle fingers are pointed toward each other as able, and move them into the position of best alignment without moving the subject's hands. Do not allow the subject to grab the fingers and pull to increase the range of motion. Perform 2 practice trials in the preferred position, then 2 test trials that are measured. Measure the distance between the tips of the middle fingers to the nearest half inch, regardless of alignment behind the back. Indicate a minus if the fingers do not reach, and a plus if the middle fingers overlap.
Makanya biasanya saya coba.
Record the better of 2 trials.
Biasanya saya rilis juga subscribe kamu.
Sakit. Saya ni tukang geli.
Kalau sakit nggak gede.
Leave me alone.
Okay, so this is the back stretch test. So it's also if people come with the shoulder problem, you can do this chest before and after the treatment to see if they have any improvement. So normally, if you do this test for yourself, you can see normally it's the left side or your right side is not in balance.
Ini masalah kolagen juga. Kolagen. Kamu ngapain? Mau terbang?
I'm ready to take off.
Implies an anterior.
Oh, yeah.
Hello, doctors. I am Dr. Donald Rosello, championship chiropractor in Las Vegas. Manual muscle testing of the deltoid is performed with the patient seated in good posture. We want to test the anterior, lateral, and posterior heads of the deltoid. To test the anterior head, we're going to have the patient, the patient's shoulders are in neutral and they are flexed to 90 degrees. The doctor contacts the humerus and is going to apply force into extension as the patient resists. Go ahead and resist. Relax. Turn some facing him. To test the lateral head of the deltoid, the patient is going to abduct their shoulders to 90 degrees and they can flex their elbows to 90 degrees. The doctor is going to contact the humerus and is going to apply an inferior force as the patient resists. Relax. And to test the posterior head of the deltoid, go ahead and turn. The shoulders are abducted to 90 degrees. The elbows can be flexed to 90 degrees. The doctor contacts the posterior humerus and applies an anterior force as the patient resists. Go ahead and resist.
Pagi tadi saya chop itu ginger. Chop my dikit lagi chop my hand.
Hello, doctors.
The
my
test
goodness,
is
come on,
a
the mobile.
restricted range of movement test. It means it's applied by
Always more.
professional, not applied by the patients. So you need to do for the patients. Then let's.
Bisa keren.
Saya coba di sini.
Oh, this is the external rotation.
Setelah rotation yang mana ya?
Makan
At
lagi.
Coles, you can do Easter in the garden or off the grid with Coles Australian Boneless.
In this video, we will take a closer look at the external rotation lag sign to diagnose full thickness rotator cuff tears.
Teachers.
Check out our online courses now. The link is in the video description.
Hi, and welcome back to PhysioTutors. Assessing a rotator cuff tear that is functionally impeded is an essential part of your assessment. The test might inform you of the need for ultrasound imaging to confirm the tear or to refer the patient to an orthopedic surgeon. The test was originally described by Hertel et al. In 1996 in a paper where several other tests were presented. Castaldi et al. In 2009 found a sensitivity of 56% and a specificity of 98% for isolated lesions of zone 3 and 4 of the supraspinatus seen here. This means that patients without tears in this zone are correctly excluded with a negative test. Do note that these values are biased by the sample. In this case, the patients were recruited via a surgeon's office, meaning that the sensitivity and specificity will be inflated compared to other settings. However, the updated meta-analysis of Hedges in 2012 included 4 more studies and recommends the use of this test for diagnosing infraspinatus tears. A systematic review by Hackmans et al. In 2013 showed that the positive predictive value of this test was the highest among all included tests for diagnosing a full tear. This is why we rate this test as having moderate clinical value. The patient is positioned at an examination couch facing away from you. You gently bend the elbow to about 90 degrees, while the shoulder is slightly elevated around 20 degrees in the scapular plane. Position in full external rotation. Then
Okay.
you slightly reduce the range about 5 degrees to prevent false positives due to elastic recoil. You instruct the patient to actively hold the external rotation while you release the wrist, providing only support at the elbow. A positive sign is observed when there is a noticeable lag or drop in the angular position. A word of caution: supraspinatus tears can occur in different patterns. Partial thickness tears may manifest on the joint side, the bursal side, or within the tendon itself. Full thickness tears can involve the anterior or posterior part of the tendon, or both. Additionally, tears can result in cleavage or delamination. In some cases, larger tears may extend into the infraspinatus and teres minor tendons, or anteriorly into the subscapularis tendon. This complexity makes the test harder to interpret, so use it with caution. Alright, that's it for this video. If you are new here, consider subscribing and leaving a thumbs up for new videos. Check out the link.
14 ini lah.
ST.
14 ini.
TE.
Iya, TE 14 ini.
Yeah, and we also,
Bisa 11, 12,
Kamu ngomong SI 14.
11, 12, 13.
Pokoknya ini 14 ini 15.
14, ya, dan 15,
16. LI.
No, TI.
NCF has won more cancer
Santai,
health
nggak ada di
insurance awards than
sini.
any other fund.
Nggak ada.
Is that
Ini
exciting?
LI 16. TE gak ada. TE gak ada di sini. TE di
Internal
sini.
rotation
Iya.
resistance strength test is used to test for primary impingement or internal impingement of the shoulder. The starting position for the test is 90 degrees of shoulder abduction, 90 degrees of elbow flexion, and around 80 degrees of external rotation. With the patient's arms supported beneath the elbow, use the other hand to apply resistance. External rotation strength can be tested by instructing the patient to maintain this position while you apply an anterior force from behind the forearm. Internal rotation strength can be tested by instructing the patient to maintain this position while you apply a posterior force through the forearm. Comparatively, internal rotation weakness may indicate an internal impingement of the supraspinatus and infraspinatus tendons between the posterior superior part of the glenoid limb. External rotation weakness may indicate a primary impingement type pathology, but it is typical for internal rotation to be the stronger of the two movements.
okay, so we'll all practice this test after we finish this lesson. So we have about 1 hour to practice for each other for this all of this test. So now we have 10 minutes break, and